The topic is treatment benefit of CDK4 inhibitors in HR positive, HER2 negative metastatic breast cancer in clinical trials and the real world. That would be the topic of discussion. And so happy to have you on the dais. And I would give hand it over to Dr. Anju for her inputs.
Should I start now, Pooja?
Yeah, ma'am. We'll just go live and you could start now. Rukaya, we are good to go. Rukaya, I'm not able to hear.
Rukaya, please confirm.
Hello, ma'am. Hello, ma'am. We are good to go.
Yeah. So let's go live then. Yeah.
So good evening, everyone. First of all, thanks to Pfizer Oncology for giving me this opportunity to moderate.
Yes, ma'am.
First of all, I'll introduce my panelist. First panelist is Dr. Indu Bansal. She is a director in Narayana Hospital.
Hello, ma'am. Yes, we are live.
She is a director Radiation Oncology in Narayana Hospital, Gurugram. And second panelist is Dr. Vipul, who is professor in Cancer Research Institute, Himalayan Hospital, Dehradun. So quickly coming on the topic of discussion today is treatment benefits of CDK4/6 inhibitors in HR positive, HER2 new negative advanced breast cancer in clinical trial. So this is the table showing different trials of CDK4/6 inhibitors. Different trials are Mona Lisa trial, Monarch trial, Paloma trial. As can be seen in Mona Lisa trial, CDK4/6 inhibitor uses ribociclib. In Monarch trial, this CDK4/6 inhibitor used is abemaciclib, and in Paloma trial, it is palbociclib. In Mona Lisa trial 3 and in Monarch 2, this CDK4/6 inhibitors along with endocrine therapy were used as a first line and in second line settings. But in Paloma trial, it was used Paloma 1 and Paloma 2, it was used as a first line setting. This is the polypharmacology of FDA approved CDK4/6 inhibitors, that is abemaciclib, ribociclib, and palbociclib. Here, palbociclib has similar potency against CDK4 and CDK6, but abemaciclib and ribociclib have greater potency against CDK4. Abemaciclib also inhibits CDK1, CDK2, CDK5, CDK9, as can be seen. So, all these inhibitors are a cell cycle in G1 phase, resulting in growth inhibition, but abemaciclib inhibits cell cycle in G2 phase also. In ASCO 2022, also overall survival was presented with first-line palbociclib plus letrozole versus placebo plus letrozole in women with estrogen receptor positive, HER2 new negative advanced breast cancer, as analyzed from Paloma 2 trial. So background of this trial was palbociclib was the first CDK4/6 inhibitor approved as treatment for ER positive, HER2 new negative advanced breast cancer based on the results from Paloma 1 in 2015. This Paloma 2 is a randomized double-blind phase 3 study demonstrated statistically significant and clinical meaningful improvement in the primary endpoint of PFS, confirming the findings of Paloma 1. After a median follow-up of 23 months, median PFS was 24.8 months with palbociclib plus letrozole versus 14.5 months with placebo plus letrozole. At the time of final PFS analysis, OS data was not mature, and final OS analysis was performed after required events were reached in November 2021 with median follow-up of 90 months. Eligibility criteria in Paloma 2 study, all postmenopausal women with ER positive and HER2 new negative advanced breast cancer were taken. Patients who did not take prior treatment for advanced disease were included, and they were having performance status of 0 to 2. Patients were randomized on the ratio of 2:1. total 666 patients were there. In the treatment arm, 444 patients were there. In treatment arm, palbociclib was given 125 mg per day, 3 weeks on, 1 week off, and along with letrozole, 2.5 mg daily. But in the control arm, placebo was given at the same dose of 125 mg per day, same as 3 weeks on, 1 week off, plus letrozole 2.5 mg daily. Primary endpoints were the progression-free survival, and secondary endpoints were the overall survival, along with response, safety, biomarkers, and PRO. PRO is patient-reported outcome. Stratification was done on the basis of disease site, like patients whether having visceral or non-visceral metastasis, disease-free interval, whether patients were de novo metastatic or having DFI less than 12 months, or disease-free interval of more than 12 months. Whether these patients took prior neoadjuvant or adjuvant hormonal therapy or not. So primary endpoint statistical assumptions for PFS was 44% improvement in this study group from 9 months in the control arm to the 13 months for the test arm. And assumptions for overall survival was 35% improvement from 34 to 46 months. So this is that graph showing PFS in Palomar 2 study, and in both the arms, as can be seen, it was 14.5 months in the control arm and 24.8 months in the treatment arm. When updated analysis was done, this progression-free survival further increased from 24.8 months to 27.6 months. This is the table showing demographic and baseline characteristics of different subgroup in both the arms. As can be seen, these both arms were comparable. This is the survival disposition of the patients, as can be seen in Palomar 2 study. 25% patients were alive at the end, and in the treatment arm, and in the control arm, only 19% patients were alive. Now, further stratifying patients, 10% patients from 25%, 10% patients were still on the treatment at the end in the treatment arm, and in the control arm, only 2% patients were still on the treatment. This is the graph of overall survival in both the arms. As can be seen, there was overall survival of 53.9 months in the treatment arm, that is palbociclib plus letrozole arm, and it was 51.2 months in the control arm. So it can be seen there was only 2 months gap. Now, when we further go into deep details in different subgroup and compare the overall survival results were almost similar to what we saw in the study group in the Palomar 2 trial. But there was a statistical huge difference between the patients who were having performance status of 0. Here, like there's a difference. These patients were in the favor of control arm. Like patients who received placebo plus letrozole were having better results in performance status 0 subgroup. And these patients were having huge difference of missing survival data. Like 11% of patients were having missing survival data in this subgroup in comparison to 28% in the control group. So this subgroup had maximum disproportionate missing data between these two arms. This is the subgroup which had the least disproportionate missing data. This subgroup were the patients who had performance status between 1 and 2, patients who were having disease-free interval of more than 12 months, patients who took prior chemotherapy, and patients who were having bone-only disease. In these subgroups, results were in favor of palbociclib plus letrozole arm, as can be seen in this. So this is the graph showing sensitivity analysis of overall survival in between two arms. As can be seen, median overall survival was 51.6 months in palbociclib plus letrozole arm, and in the control arm, it was 44.6. Like initially there was a difference of 2 months. Here differences of 7 months. So further numerical overall survival improvement favoring palbociclib plus in combination with letrozole, and indicating the impact of missing data. So when we combine the results of Paloma 1 and Paloma 2, we see there is a difference. Like when we combine results of these two trials, median overall survival was 51.8 months in the treatment arm, that is palbociclib plus letrozole arm, and it was 46.8 months in the control arm. When we go into further sub details, like patients who were having disease-free interval of more than 12 months, this difference increased. Like median overall survival in this subgroup in the treatment arm was 64 months, and in the control arm, it was 44.6 months. This is the table showing patients who took systemic therapies. Like after completion of this study, some patients went into endocrine therapy, some patients took chemotherapy, and some were still on the CDK4/6 inhibitors. So it was seen that 12% patients were still on CDK4/6 inhibitor in the test arm, and among them 9% patients who were continued taking palbociclib in the test arm, and 24% patients continued on taking placebo in the control arm. This is the graph showing time to chemotherapy in months. Like patients in the treatment arm took 38.1 months to receive chemotherapy later on, in comparison to 29.8 months in the control arm. That means patient in the palbociclib plus letrozole arm did better. This is the table showing different clinical trials and comparing the different subgroups. So it can be seen patients who were having disease-free interval of less than 12 months, these were 22% patients of this subgroup in Paloma 2 trial, but in Monarch 3 trial, these patients were excluded. And in Mona Lisa 2, only 1% patients of were there who were having a DFI of less than 12 months. So this is the table showing difference in endocrine sensitive population in different trials. In Paloma 2 trial, like patient who were having disease-free interval of less than 12 months were only 22%. But when DFI is more than 12 months, these patients were 40%. In Mona Lisa 2, DFI when less than 12 months, these patients were only 1%. And DFI when more than 12 months, these were not recorded in Mona Lisa 2. But in Mona Lisa 7, patients who were having DFI less than 12 months were of 7%, very less than Paloma 2. And patients who were having DFI more than 12 months of 53%. In Mona Lisa 3, it was 80%. And in Monarch 3, DFI patients having DFI less than 12 months were excluded. And patients who were having DFI more than 12 months were 60%. So till now, we have discussed different clinical trials, their outcomes, their different subgroup analysis. So now question of discussion is, this question goes to Dr. Indu. Dr. Indu, what do you think about the Paloma 2 subgroup results of patients who were having disease-free interval of more than 12 months, like endocrine sensitive group?
So I think this patient definitely did better with palbociclib plus letrozole combination versus the placebo arm. And although, I mean, what I could understand from the study was that although the overall survival was not much different in palbociclib group versus the placebo group, there was difference of only 2 months. But definitely the time to disease progression, need for chemotherapy, and disease-free survival, that was definitely better in the study group. Yeah.
So do you think DFI more than 12 months subgroup is driving overall survival benefit in other clinical trials?
I don't know the answer to this.
Because it is shown like when DFI is more than 12 months, these patients were more in other trials.
More in other trials, yeah. And
Yeah.
Mona Lisa and other trials, they
Yes,
were more.
monarch trials, but these number of patients were definitely less in Palomar too.
Yeah.
So it might have affected the overall survival in these subgroups.
Yes.
So, Dr. Vipul, do you agree that 22% of endocrine resistant population has impacted the overall survival results of Palomar 2?
Yeah, ma'am, it could be. But we have to look the reason for resistance of the CDK inhibitor by looking the gene mutations like ARS1 mutation or
Yeah, we
some
have to go into deep
PIK3
details.
mutation.
Yeah.
So then after that, we can conclude that the patient is having resistance to the CDK inhibitor.
So, what?
Because these tumors are most of the time a slow growing tumor.
Yeah.
So the more slow growing tumor, the radiobiologically that will have more benefit from the CDK inhibitor. This is basically the uh, principle behind of CDK inhibitor. Yeah.
So, what percentage of patients in your clinical practice have DFI more than 12 months or less than 12 months?
So my experience, almost most of the patients what I prescribed is more than 12 months. Patients has received. 2 or 3 patients got resistance, but they were after the 18 or 19 months, they got resistant from the palbociclib. Then on liquid biopsy, they got mutation on the PIK3,
Okay.
PIK3C mutation. So prescribed on the alpelisib along with the fulvestrant.
Okay. And what about you, Dr. Indu? In your clinical practice, patients having DFI less than 12 months or more than 12 months? What percentage of patients do you see in your clinical practice, Dr. Indu?
Yeah, I'm mainly a radiation oncologist. So my patients, they go to medical oncologist. So I will not be able to give an answer to this, but
Okay.
yeah. So, but I have seen patients, whatever patients I have seen who are receiving palbociclib, they do, if they tolerate it well, then they do better. The disease-free interval is more than 12 months.
So, Dr. Vipul, how do you go like patients when have CDK4/6, what is your clinical experience with CDK4/6 inhibitors in your endocrine resistant patients?
The endocrine resistance patients basically by the letrozole AI resistance. If patients has resistance with the AI, then we can shift over the fulvestrant plus palbociclib. Because many times I've seen the previously that patient was not prescribed for the palbociclib because it was very costly. So the patient was on the hormonal treatment, and then after the letrozole, they got progression. So then we switch over to the fulvestrant and palbociclib. Then patient had good
Right.
response. For almost 1.5 years, she was the disease stable. What we can say, PFS was very good, almost DFS.
Right. So in Palomar 2, there was a 13% patients in the treatment group. That is like patients who received palbociclib plus letrozole. There were 13% patients were having missing data. And in comparison to 21% patients in the control arm, that patients who received placebo plus letrozole, there were 21% patients were there who were having missing data. So do you think it has an impact on overall survival results?
Yeah, sure. If now the CDK inhibitor is coming on the adjuvant setting in the all the high risk patients, so ASCO has approved it. So as early as possible, you will add the CDK inhibitor automatically as through the biology of the tumor that you will get the more benefit in the OS.
Yeah. And here also in some randomized control trials, it was suggested that a loss to follow-up of more than 20% causes serious threats to the validity of the data, and even more than 10% results in biases in analysis.
Yeah.
So we come on to the next slide. This is slide showing National Cancer Institute Breast Cancer Steering Committee, who recommended like in settings where expected a long, patients have long survival after treatment. So their progression-free survival can be considered most appropriate endpoint instead of overall survival. So question of discussion here is considering Palomar 2 data readouts and their limitations. Dr. Vipul, do you consider overall survival is a better outcome, a better class effect for all CDK4/6 inhibitors? Dr. Vipul.
No, ma'am. The basic rationale behind the CDK4/6 inhibitor is same for all the molecule, whether it is palbociclib or ribociclib or ribociclib. So we cannot say that there is a limitation with the palbociclib. I don't think so.
Of course. So now we come on to the adverse events. As we all see adverse events in our clinical practice, most of the adverse events are neutropenia and leukopenia. And these were of grade 3 and grade 4. All other side effects were manageable easily. So conclusion of Palomar 2 trial is Palomar 2 met its primary endpoint of improving PFS and other secondary endpoints. Overall, a response rate of 55.3% was seen in palbociclib plus letrozole group versus 44.4% in control group. The safety profile of palbociclib plus letrozole remains consistent with long-term use without evidence of cumulative toxicity, and quality of life was well maintained. Overall survival was numerically longer in the treatment arm versus the control arm, but the results were not statistically significant. Median survival of over 50 months in this population represents a significant improvement in the natural history of HR-positive breast cancer, and this is highlighted in the subgroup of patients who were having disease-free interval of more than 12 months. Here, median overall survival was 66 months. So now we come on to the real world data. Real world data, it is a retrospective observational analysis of electronic health records using patient data from the Flatron Health Analytic Database. Here, key features of this database is size of database is quite large, like over 3 million patient records were there. And there were experienced across different clinical settings, like more than 280 community cancer center patients were there and 8 major academic center patients were there. And this was a single common data set where different features were there of patients. Objective of this study was to evaluate the effectiveness of first-line palbociclib plus aromatase inhibitors as compared with aromatase inhibitors alone in patients with HR-positive, HER2-negative metastatic breast cancer treated in real-world practice. Method was retrospective cohort analysis of electronic health records with the US Flatron Health Analytical Database was taken. Patients included were the postmenopausal women and men aged more than 18 years with HR-positive, HER2-negative metastatic breast cancer. Total 2,888 patients, data of 2,888 patients was included. Study design was from 3rd February 2015 to 31st March 2020. And follow-up was follow from index date to death, study end, or last visit, whichever occurred first was taken. There were 2 arms, palbociclib plus aromatase inhibitor arm and aromatase inhibitors alone arm. Endpoints were the overall survival and real-world progression-free survival was the secondary endpoint. Here, 2 statistical analysis was used. We will see in a later slide. So basically, here, bias can also occur in real-world data because treatment selection is often influenced by subject characteristics. So to reduce this, 2 statistical analysis was taken into account. One was IPTW and other was PSM. So this method was used to create a pseudo population where all the patients treated and untreated resemble some reference population. Because sometimes a single or few patients with extreme weights can have a big impact on the analysis, potentially giving high imprecise estimates. So by using these techniques, we can reduce the bias. So one is propensity score matching, that is PSM. It is a statistical method that can be used to create balance between treatment groups in the absence of randomization. When PSM is used, the number of patients who are in the analysis are reduced by selecting only those patients who match across the cohorts. Another statistical approach is inverse probability treatment weighting, that is IPTW. This is a method to add the difference in baseline characteristics of study subjects in the groups to be compared. We will not go into deep details. This is the basic characteristics in different subgroup in both the cohort, and these were almost similar after adjusting these scores with these statistical analysis. So now we come on to the results. This is the graph showing overall survival in unadjusted analysis and when we apply EPTW and PSM. In unadjusted analysis, overall survival was 53.4 months in the test arm, and in the control arm, it was 40.4 months. When we apply IPTW, then it comes to be 49.1 months in the treatment arm and 43.2 months in the control arm. When we apply PSM also, it comes to be 57.8 months in the treatment arm and 43.5 months in the control arm, increasing the gap. So median overall survival was significantly longer among patients who received palbociclib plus aromatase versus aromatase alone before and after these adjustments. So this is the data showing overall survival in different subgroups. Here it can be seen results were similar, which were seen in randomized controlled trials in Paloma 2, except in two subgroups. One is patients who were younger, having age between 18 to 49 years, and patients who were having brain metastasis. Here it can be seen that results were in the favor of patients who received placebo plus aromatase inhibitors, crossing the unity line. So progression-free survival in real world in unadjusted analysis and after adjusted. So in unadjusted analysis, progression-free survival was 19.8 months in the treatment arm and 13.9 months in the control arm. When we apply IPTW, it was 19.3 months in the test arm and 13.9 months in the control arm. When we apply PSM, it was 19.8 months in the test arm and 14.9 months in the control arm. So median real-world PFS was significantly longer among patients who received palbociclib plus aromatase inhibitors versus aromatase inhibitors alone before or after applying this statistical adjustments. So what were the strengths of this real-world data? The sample size was large. This Flatron database captures and processes detailed patient's information. There was the availability of comparative control arm that allows a comparison of treatment similar to randomized controlled trials after adjusting for potential confounders, and follow-up time was sufficient. Limitations of this real-world data was study is a retrospective database. Disease progression was based on the treating physician's clinical assessment or interpretation of radiographic or pathologic results rather than standard criteria. Some subgroup analysis may not have sufficient power due to sample size, like patients who were younger. There were very less number of these type of patients in the real world data. Two statistical analysis was applied, and findings presented here may not be generalizable to patients' populations not represented in the Flatron database. So conclusion of real-world data was, in real-world study, palbociclib plus aromatase inhibitors were more effective than aromatase inhibitors alone in a heterogeneous population of patients with HR-positive, HER2-negative metastatic breast cancer and among various patient subgroups. This evidence supports the use of palbociclib in combination with an aromatase inhibitor as a standard of care first-line treatment of patients with HR-positive, HER2-negative metastatic breast cancer. So nowadays, real-world data play an increasingly important role in expanding use of already approved medications in different clinical trials. So till now we have sufficient wealth of data. So Dr. Indu, can you tell us considering the wealth of data of CDK4/6 inhibitors across different randomized controlled trials and real world evidence, do you think that there would be any change in the treatment practice among CDK4/6 inhibitors? Dr. Indu.
Definitely feel that with the current evidence that we have, CDK4 inhibitors are making a difference in the lives of patients by improving the progression-free survival, and as well as we are getting some data which points towards improvement in overall survival as well. So earlier, people would use just switch over to the second line of aromatase inhibitors or not add CDK4/6 inhibitors, but this is changing now. I just feel that, of course, for young patients, say 50, 60 years age group, or this should be definitely be added whenever possible. For very elderly patients, say above 75, 80, I think we need to do a very close monitoring.
Yeah.
Because of too much toxicity that has been seen, specifically neutropenias, asthenias, and so in my experience, what I've seen is that young patients, they do tolerate it well, but for elderly patients, it has to be given with caution.
So now next question is to Dr. Vipul. What is your experience about palbociclib? What efficacy do you see in your clinical practice? How do you monitor? What are the side effects in your clinical experience? Share your attributes.
What I experience, it's generally the patient tolerated very well. The side effects is only grade 3, grade 4 due to pancytopenia in some selected patients. So in those patients, we can reduce the doses of 125 to 100 mg lower doses. So this is the only the elderly patients basically is having the more compromised bone marrow. So in those patients, we can reduce the doses also. But otherwise, it's a better tolerated disease. Well, this drug is better tolerable. Tolerability is good.
So how many percentage of patients in your clinical practice with palbociclib do you see neutropenia?
Almost I saw all patients were having the neutropenia, but it depends on the grade. So most of the patient grade 1, grade 2 neutropenia.
Exactly.
I haven't seen any patients grade 3, grade 4 neutropenia.
Yeah. Then we have to reduce the dose only.
Yeah. We have to monitor every 2 weekly CH blood counts. If patient is having grade 3, grade 4, then we have to reduce. Otherwise, no need to reduce.
No need to
Not
reduce.
in a grade 1.
So we have seen randomized control trial data. We have seen real world data. Now we will see some Indian experience with palbociclib. So this is the study done in RGCI and BLK hospital. This is the real world evidence of palbociclib used in metastatic hormone positive HER2 negative metastatic breast cancer in Indian population. Here 188 patients were included, and patients metastatic HR positive HER2 negative metastatic breast cancer patients who received palbociclib plus aromatase inhibitors or palbociclib plus fulvestrant between February 2017 to May 2020 were included. Patients who were premenopausal, they received ovarian suppression or ovarian ablation along with this treatment. Here also, we can see median progression-free survival was 20.2 months in the first line setting when these agents were given in combination, and when they were given in second line setting, it was 12 months. Even overall response rate was 80% when given in first line setting and 47.9% when given in second line setting, corresponding to what we see in clinical trials. This is the study done in, I think, South India. This is the multi-center retrospective study. Here also, results were almost similar. Neutropenia was seen in 75.2% patients. As we all see in our clinical practice, most of the patients were having grade 1 or grade 2. Grade 3 neutropenia was in 23% patients, but no patient had febrile neutropenia. So conclusion was palbociclib has resulted in similar efficacy and safety in Indian patients also, as we saw in Paloma trials. Neutropenia was the commonest side effect, which was uncomplicated and easily managed with dose delays or dose reductions. Using CDK4/6 inhibitors with hormone therapy has become the standard of care nowadays in HR positive metastatic breast cancer Indian patients also. So this study is also from Chennai, resulted in same results. This is a study done in Jaipur, hormone receptor positive, HER2 negative metastatic breast cancers treated with palbociclib. 67 female patients were commenced on treatment with palbociclib between 2016 November to May 2020. Total of 76% of these patients were postmenopausal and other were premenopausal. Bone only metastasis was seen in 25% patients, visceral mets having 45% patients, and remaining 20 had bony and visceral mets. So here also results were in favor of palbociclib. This is the outcome in patients. In these patients, median progression-free survival was 18.7 months. And in the treatment arm, when these agents were given in first-line setting, when in comparison to 13.8 months. So palbociclib is a useful addition in the management of HR positive, HER2 negative breast cancer patients. Its benefit is confirmed in our clinical world setting, clinical trials and real world setting, both in the first and subsequent lines of therapy. And data are on similar lines as the global data on palbociclib effectiveness. So this is the practical consensus recommendations regarding the use of this palbociclib therapy in metastatic breast cancer. Take-home messages are, in patients with metastatic breast cancer, available evidence does not support local regional treatment. The decision should be individualized based on patient and tumor characteristics, site and number of metastasis, and response to systemic therapy. Endocrine therapy rather than chemotherapy is preferred in patients with HR positive metastatic breast cancer. Chemotherapy may be offered for those who are highly symptomatic and visceral crisis needing rapid tumor response. A combination of aromatase inhibitors and palbociclib should be preferred first-line hormonal therapy for HR positive metastatic breast cancer. Premenopausal women need to undergo ovarian ablation before starting aromatase inhibitors with palbociclib. If treatment with palbociclib is not feasible, aromatase inhibitors should be offered. In patients with bone-only disease, fulvestrant may be offered over aromatase inhibitors. So, combination of fulvestrant and palbociclib should be offered to patients who have progressed on aromatase inhibitors. Exemestane plus everolimus is another option. This is the efficacy and safety of palbociclib in treatment of HR positive advanced breast cancer. This is ASCO 2022 presentation. Here objective response shown was 17%, stable disease 54%, and adverse events reported were 39.22%. Most reported adverse events, as we see, was a neutropenia. It was reported in 13 patients. So conclusion of these meeting was, in the present study, palbociclib plus letrozole reported good clinical response at the end of the treatment duration with manageable tolerability profile in the Indian population. So summary is, all of CDK4/6 inhibitors were designed to demonstrate a benefit in the primary endpoint, that is progression-free survival. It is the accepted primary endpoint in metastatic breast cancer by regulatory authorities around the world. Increasing evidence is available from randomized controlled trials demonstrating longer overall survival with CDK4/6 inhibitors plus endocrine therapy versus endocrine therapy alone in HR positive, HER2 negative advanced breast cancer. However, the difference in overall survival was not statistically significant for palbociclib, as we saw. Real-world evidence of associated overall survival benefit for patients treated with palbociclib combination therapy in the first line can help inform treatment decisions in clinical practice. According to worldwide guidelines, CDK4/6 inhibitors in combination with endocrine therapy are the standard of care for patients with HR positive, HER2 negative, advanced or metastatic breast cancers. So with this, I'll end. Any questions?
Thank you so much, ma'am, for this wonderful talk. I don't find any question answer in the chat box. Just a couple of things, ma'am. Post, you know that LOE of Pelbase has came, and many generics were there also in the market. So we came up with a very simplified assistance program that is 3+1. So now the effective cost of Pelbase will come down to around 18,000 per month. And I think it will empower more number of your patients to avail this innovative therapy of Pelbase. So with this, ma'am, I have actually a couple of questions. Probably doctors are not able to put it in Q&A. So, ma'am, in visceral disease, like if a patient having visceral disease, what is your treatment option?
It depends what is the age of the patient, in which subgroup patient lie, what is the what is the ERPR status, what is HER2 status. Depending on these, it is decided. So, but definitely if patient is ERPR positive and HER2 negative, patient is having progression, having visceral metastasis, we prefer to give this combination with palbociclib plus letrozole. I have n number of patients who are on this combination.
Okay, ma'am. And the second question is, ma'am, I mean, there are 3 kinds of CDK4/6 inhibitor out in the market. In what subset of patient do you prefer Pelbase or any other drug, ma'am?
Basically, patients who are having bone only disease, I think their palbociclib does better with endocrine therapy. And patients who are having visceral metastasis, here ribociclib and abemaciclib do better. And plus in CNS, if patients is having CNS metastasis like brain mets, then also abemaciclib has a better role.
Okay, ma'am. So I think the next question, I think you already answered. It is about the toxicity profile of Pelbase. So I don't think, ma'am, you have observed it in your patient also.
Yeah, mainly side effects I have observed is neutropenia. In most of the patients, patients have neutropenia, but it is easily manageable. Like we have to reduce the dose only.
Okay, and with other CDK4/6 inhibitor, ma'am?
Other CDK4/6 inhibitors like with ribociclib and abemaciclib, I have seen GI toxicity is more.
Okay, thank you so much, ma'am, for answering all these questions. So with this, I would like to thank all the panelists also, Dr. And the attending faculty member, attending physicians. So I think, ma'am, with this, we can close this meeting. And any concluding remark from your side, ma'am?
Conclusion is that patients who are having HR positive status, HER2 negative status, patients having metastatic breast cancer, they can be preferred to give palbociclib plus letrozole. And these patients really, long time, these patients go on having these combination. And I have seen, like I have patients in my clinical practice, patients are receiving this combination for 1 year, 1.5 years, 2 years also.
Thank you so much, ma'am, for your feedback. I would just like to take the feedback for the assistance program. Ma'am, how do you find the assistance? What Love had just said, will that benefit a lot of your patients, ma'am?
Definitely it will, because now you are like initially you were the only one who was having palbociclib. Now you have a strong competition, so you should have this type of patient assisted program.
Yeah, thank you so much for your feedback. I would like to take the feedback from Dr. Anju and Dr. Vipul also, if we are online.
Dr. Indu.
Dr. Indu and Dr. Vipul.
Yeah, so Pooja, I will also say now the cost has come down, and with your assistance program, it seems quite affordable. So if given a choice with your assistance program, I would like to go with the innovators rather than choosing any line of drug, because earlier many patients could not afford it because it's a long-term therapy, and like the patients who respond, they might need to take it for 2 years, 3 years, and it was draining on the pocket. But now with the patient assistance program, I think more patients would be benefited. And of course, as I said, I'm a little worried about the toxicities, because although here everyone is talking only about neutropenia, but let me tell you, asthenias and lethargy and body ache, that's also a major concern. So so that should also be looked into account. And we have to look at the quality of life of the patients, and of course, progression-free survival and length of life. So if we choose the dose of that drug carefully and we monitor the toxicity, then it's a beautiful drug to be administered to most of the patients.
Thank you so much, Indu ma'am. Thank you for your feedback. That was really great. Dr. Vipul, I would like to come to you.
Yeah, actually, basically the affordability of the patients is very. Is the company sponsored or patient is having good affordability, the automatically the innovator drug is the best drug we have to prescribe. If patient is poor, he can't afford the medicines, so then we can use the generic also. That's a good for palbociclib.
Thank you so much, Dr. Vipul, for your feedback. I'm sure the audience who's listening to it will get more motivation towards using original products. And as you discuss the data, it's really good to hear from you all. So thank you so much for this wonderful evening. Thank you. Thank you.
Thank you so much for having us here. Thank you so much.
Thank you. Thank you.
So we're good to close. Thank you. Thank you, ma'am. Thank you, sir.
Yeah, actually, basically